Hey everybody, I'm Dr. Russ Hornstein, and today I'm going to talk about migraines. Migraines are very poorly understood in the general population, both in sufferers and in doctors. It is a very, very peculiar thing, but it is absolutely treatable. I've been working with migraines for 30 years with great successes. It is very treatable. So if we understand what it is that's happening, then we can start to understand ways that we can try to change this person's symptoms or ideally resolve the symptoms. So what we first need to understand is what it is that's happening. So a migraine event is a neurological and a vascular event where the blood pressure rises to a certain point and then it drops. And so when it drops, that's when you have the headache because you don't have blood flow to your brain or enough blood flow. But also we have a rise in the blood pressure before that, which is what triggers a lot of the prodrome symptoms. So let me just get right into it and explain what it is and why it happens. So the first step of what happens in a migraine is that the blood pressure rises. Now, in order to understand what's happening there, when blood pressure goes up, what's actually happening is the blood vessel itself. So it's like a tube or a hose. Our arteries have a muscular wall, which means that when the muscle constricts, the lumen or the space inside the vessel gets smaller. So our heart is always pumping and pushing a certain amount of blood into the circulatory system. And as it goes into our arteries, those arterial walls have a certain amount of tension in them that will determine the amount of pressure. So obviously, if you're putting a certain amount of fluid through a big tube versus a small tube, the smaller tube will have more pressure in it because it's the same amount of fluid going through that smaller tube. So what ends up happening is our body can control the size of that vessel depending on our needs or our the needs of our body to get more flow of blood. So if you get excited or kind of wound up or something stimulating you, we need to increase the blood pressure to get more blood to flow to those areas. So generally when you're at rest, there'll be a certain amount of tension. And then as you become more excited or more stimulated, your body will start to constrict those vessels so that you have increased pressure and more flow. And that's perfectly normal. That's how things should be working. Now, what ends up happening in a migraine is the first phase of a migraine is that the blood pressure will start to go up. And the part of our brain that calms it down, and what we say modulates it, our prefrontal cortex, that part of our brain should be calming down just to kind of keep a little bit in check so that we don't constrict too much. But if that part of the brain isn't modulating or controlling the blood pressure very well, what can happen is the blood pressure can start to rise and rise and rise so much that it'll actually start to almost go into like a spasm. It's not a spasm, but the muscular wall will constrict and constrict, and there's nothing kind of turning it down. So what we end up with is too much constriction of that arterial wall. So the blood pressure will rise very high, and what will end up happening is the blood will go through a very, very, very small lumen, if you will. But what we have is we have control of the arteries and their size, but also the smaller arteries, we call arterioles, they still have a muscular wall. And what will end up happening is at that arterial level, the contraction of that arteriole will be so great that the space for the blood to go through will be really, really compressed. And as the blood is being forced through these very, very tight, in other words, what happens is it just constricts way too much. Those arterioles will constrict so much that we'll end up forcing the blood, which is a mixture of red blood cells and plasma and all kinds of lovely things. But what ends up happening is as you're forcing the blood into this very, very these small vessels, the red blood cells themselves get smashed against each other and they will break. So the red blood cell is like a kind of like imagine like a gummy sweet or something, or some sort of bag of lovely juices. It has hemoglobin and ferritin and bilirubin and biliverdin and all these lovely constituents that do great things for us, but they have to stay within this wrapper of the red blood cell. What ends up happening is the vasoconstriction is so great in those arterioles that as it gets forced through that space, the red blood cells themselves can break apart, and the chemicals within that, the hemoglobin, biliverdin, the ferrous iron, these chemicals are actually cytotoxic in our brain. So as the blood pressure increases and goes into our brain, and we break these red blood cells, those constituents are actually cytotoxic in our brain. So as it's going into our occipital lobe, which is the part of our brain where we have our vision, where we perceive vision, the chemicals in that area where the vessels are very, very small, which is a large degree of where this can happen, because we have such small vessels in the occipital lobe, that when these red blood cells break, that cytotoxic material will stimulate our occipital lobe and give us a visual phenomena that we call the prodrome. So prodrome is the sort of feeling or the visual sensation that you have before the pain of the headache starts. So every migraine has a certain characteristic, and one of the key characteristics of migraines is a prodrome. So it means you have this symptom before the headache starts. And what's happening at that moment is that's when those blood vessels are so tight, it's breaking the red blood cells, activating cytotoxically the occipital lobe and giving you wavy lines or little C shapes, or kind of some visual phenomena, which is basically just your brain being stimulated by these chemicals that are within the red blood cells. So that's not great, but it's not terrible. It's not gonna kill you or anything. It's not any sort of lasting negative effects. So it's nothing really to be worried about, but that's actually what's happening. But what will end up happening as well next is that the body basically can't sustain that, and you'll have a reflexive relaxation of that, because once you're still forcing blood into this very small space, it can't go anywhere, and it actually creates a response in the muscle to relax. So if you kind of stretch a muscle really hard, you can make that muscle relax. It's called an inverse myotactic reflex, and it exists in the vascular system as well. And what that does is it's like an escape mechanism. So our body will go into this escape mechanism and make those blood vessels relax, not just in the occipital lobe, but all throughout your body. The blood vessels will just relax, okay? Which sounds great, but what it means is you actually need a certain amount of tension or tone in those vessels to get blood where it needs to go. So when you have the second phase of the migraine, you have this vasodilation, the blood vessels become larger, the blood flow decreases. And if we don't have blood flow to our brain, then we don't have energy in our brain. And essentially what's going to happen is that everything that's happening in our life is stimulating us, and it's creating activation of all the neurons in our brain, if you will, specific to those stimulations. But now the neurons in our brain aren't getting fuel. So if you try to work the brain without fuel, you'll have a headache. So the migraine headache is from not getting enough blood flow to your brain. So that's why everything that's stimulating you makes it worse, because essentially you're driving the system without getting it fuel. So that's why you want to lay down, go into a dark space, have no noise. These are all important things because it's going to decrease the stimulation to your brain and make the pain a little bit less. Okay, so anything that's stimulating you more is going to make the pain worse. So this is basically it. This is how a migraine works. And then your body has to essentially recover from that. So here's another missing detail, is that our blood pressure is controlled, like I said before, from our prefrontal cortex can actually modulate the blood pressure, in other words, lower it down. And if the prefrontal cortex isn't able to do that function, then the blood pressure has the potential to rise. So things that stimulate us, like caffeine, sugar, chocolate, red wine, all these things that we know are stimulants are things that can trigger a migraine. Now, it's not necessarily that that is causing the migraine, but what you're doing is you're throwing a stimulant into an unstable system. So anything that can overstimulate, even stresses that can be activating your sympathetic system, but without having the capacity to lower that and modulate that, then you'll end up being a perfect candidate for a migraine. Now, one other aspect of that is that our body controls our blood pressure differently on one side and the other side. So it sounds a little bit strange. You have one heart beating and you have arteries going all over your body, but the circulatory system, or the vascular system on the left and the right, are controlled separately. So yes, they should be balanced, absolutely. But what can happen is if our left prefrontal cortex is functioning at a lower electrical level, specifically to the control of that the vascular tone, then what will end up happening is if you don't have that control, then the left side might have a greater potential for losing the modulation and letting that blood pressure rise up. Now, one of the things that's a great clue for us diagnostically is that when we check the blood pressure on the left and the right side of the body, we'll often see that there's a difference, okay? Not in everybody, but certainly in migraine sufferers. So there's three key things that you'll always see, or I will always see, in a migraine sufferer. A true migraine, now there's lots of reasons for having headaches, but a true migraine always has three key findings. And if I don't find these findings, I did not classify it as a migraine, but every true migraine has these three things. So the first is a difference in the blood pressure from one side to the other. So we check the blood pressure in both arms, and we'll find that if there's more than 6 millimeters of difference in the blood pressure from one side to the other, then that's significant, okay? Generally, people that are migraine sufferers will have 10 or more millimeters of difference in either systolic or diastolic pressures. So this is a key. So that's one of the first things. The second is a prodrome. So this symptom that you have before the headache hits is essential. If you do not have a prodrome, you do not have a migraine. It's 100% in every migraine case. Now, some people will also have nausea and disorientation, and that can definitely be a part of it as well. But we have to have some prodrome, otherwise it is not a migraine. And the third thing is pupils that dilate to light. So our pupils control the amount of light that's coming into our eyeball and affecting our retina. So our ability to constrict that the pupil is actually a representation or a function of the same part of the brain. So our prefrontal cortex will be able to, if it's working well, when there's more light coming into our eyeball, it will be able to constrict the pupil and maintain that constriction. Everybody that has a migraine, when you shine a light in their eye, what will happen is the pupil will constrict and then dilate again. Because what's happening is the brain might be able to constrict the pupil, but it cannot maintain that function because the prefrontal cortex is fatiguing and failing. So what we'll see is we'll shine a light, the pupil will constrict, and then it will immediately, within less than a second, dilate again. So those are the three key things. So why does this happen? Why does our prefrontal cortex suddenly not work? Well, that's a more complex question, and it's certainly something that you can bring up with your doctor. As a neurologist, the way that we look at it is we have to ask, what is it that's stimulating that prefrontal cortex? What is it that's activating that or giving the potential of that prefrontal cortex to function? So activation and potentiation are kind of different things. Activation is something specific, and potentiation means you just give it the energy it needs to work. So if we're looking at the prefrontal cortex and its ability to work, we have to say, well, what gives it the potential to work? And what gives it the potential is activation or potentiation, stimulation, if you will, from receptors, or what we call tonic receptors, receptors that are constantly giving stimulation to the brain. So we have this activation of sensors that are generally what we call graviceptic sensors, or sensors that are sensing our position in relation to gravity. And these receptors are activating our brain and giving it the potential to function. So I go into that in much more detail in other videos, so I'll leave that for a later video. But well, just for your sake of understanding, if we find that there's a deficit in this afferentation or this stimulation that activates through the thalamus to the prefrontal cortex and gives it the potential for function, if we can find an imbalance in those inputs into our system, and we can resolve that, in other words, getting more stimulation into certain receptors that activate that prefrontal cortex, then we'll see the prefrontal cortex will switch on and the headaches will go away. So once you can figure this out, it's very, very common that within a treatment or one treatment, and usually a treatment and a follow-up, we can see a very, very significant decline or complete resolution of the migraines. So again, migraines are not difficult to treat. They're difficult to diagnose or difficult to understand. Once we understand it, it's not so difficult. Once we know what windows to look through diagnostically, again, we're looking for prodromes, differences in the bilateral blood pressure, and pupils that dilate to light. If we can determine and use those indicators to steer us towards, and other examination findings to steer us towards where there's a deficit of that activation of the prefrontal cortex, then we're well on our way to resolving the issues. So I hope that gives a little bit of an explanation. That's my best explanation in however many minutes that was, of how a migraine works. I think if more doctors knew about this, there'd be far fewer migraine cases and a lot more happy people out there. So it's not difficult. There's hope for everybody. It's not a difficult thing to treat, and it's something that can usually be resolved very, very quickly. So I hope that sounds interesting to you. If you have any questions, fire them off in the comments and I'll be glad to address them. Thanks for watching.